Good morning. I'm Kim Kuebler, the Editor-in-Chief for the Multiple Chronic Conditions Resource Center, and we are happy to introduce Dr. Matthew Sorenson. Dr. Sorenson is a professor and associate dean for graduate education at Texas A&M University in College Station. Prior to coming to Texas, he was at DePaul University in Chicago for 5 years, where he served as director of the School of Nursing for 3 years. He completed a postdoctoral education and 3-year fellowship with a neurology service at Edward Hines Jr. VA Hospital, with a focus on multiple sclerosis and a year-long fellowship in disability ethics through the Rehabilitation Institute of Chicago. He is an adult nurse practitioner working primarily with street outreach programs targeting the homeless and working poor. As an educator, he teaches program evaluation and pharmacology. His research focuses on immunologic correlates of fatigue, particularly in those with multiple sclerosis. He is the editor-in-chief for chronic illness. He is going to be speaking on the immunologic factors associated with multiple chronic conditions. So, Dr. Sorenson, very impressive background. Can you help us better understand what the role of the immune system is in chronic disease?
So, thank you. And thank you for that kind introduction. And it almost might be better to ask, what isn't the role of the immune system in chronic disease? Because the immune system really plays a significant role in not only chronic disease, but then also an exacerbation of other diseases in terms of particularly diseases with a lot of chronicity. Things like asthma, bronchitis, even worsening of several cardiovascular diseases. So in many ways, it's almost better to say what isn't the role, because it's very intimately linked in terms of disease states worsening, and also it's the target of most of the medication treatments we really incorporate and utilize in the management of many chronic diseases. And that's not even touching upon autoimmune diseases, of which it obviously plays a major role. There is a couple of slides for those who are not as familiar with the immune system to just kind of help explain what it is we're talking about when we talk about immune factors and proteins and those types of things. So we have a couple of arms of the immune system. One's just referred to as adaptive, and then there's the innate. And innate is what we're born with, and that includes barriers. That includes the skin, that includes the cells that we have lining the GI tract. This includes anything that poses a wall or resistance to organisms coming in and impacting us in some way. And also there's, for a brief period of time, there's some immunity that's passed on for our mothers, but that's very brief and doesn't last more than maybe 18 months max. And it's slowly just titrating down as it goes. But we also have these other cells that are referred to as natural killer cells and other things, phagocytotic cells, that also can that are part of that. Those cells are also, though, influenced by what we refer to as adaptive. And when we start talking about vaccinations, that's really what we're trying to target. We're trying to target cellular memory. T cells in particular, those will help kill off pathogens. They help attack infected cells. And then we have B cells that are making antibodies as well. And there's memory cells of both groups that are what we're doing with vaccination. We're trying to increase the number of those memory cells, so if something comes at us, the body goes, I recognize this, and then it can attack and hopefully destroy it and protect us from some kind of infection or something else. And I have a couple of slides that just show how one of them shows how complex this can be, that there's different arms to all of this. The T cell line, the B cell line, there's different types of T cells, there's a couple different forms of B cells, so it can become fairly complex fairly quickly. But the immune system just plays a huge role. It helps defend us against disease states, particularly infections, but then it also provides a huge contribution to the development of disease and disease progression in and of itself. So we have this defensive response that triggers off a process of inflammation. And there's a lot of elements to inflammation, but basically we can say that if something comes at me, I get infected by something. Say I'm walking down the hall and I step on a rusty nail or something like that. My body's going to respond to that. And it's going to respond to that by process of inflammation. When it becomes a problem is when that process of inflammation is not turned off. So there's these responses that say, here's something that's coming after us. It's foreign. We don't recognize it. And that's what's happening with autoimmunity. Our body's thinking parts of us are something else, and it's trying to defend us. But there's a correspondent part of cellular proteins. We tend to call them cytokines, and there's lots of different subgroups, and there's lots of them. But basically, these proteins are involved in a process of inflammation and defense, but then there should be a correspondent response after a period of time that then turns them off. And what we start to see as we age in particular, and with people who have chronic diseases, we don't see that suppressive quality come in. It just keeps going. And then that's what we're having for autoimmune diseases, multiple sclerosis, type 1 diabetes. We can have lupus. We have numerous disease states where the immune system is attacking us. But then as we go on, then a lot of other chronic diseases lead to this anemia of chronic disease. Obesity in and of itself is considered to be an inflammatory state nowadays. And there's a term that people are starting to coin that it's not the best term, but it's called inflammaging, which is trying to describe that ongoing process of inflammation and how it basically is leading to disease states.
Very interesting. When we talk about the immune system, is there a pattern or specific phenotype that's associated with chronic disease? I know you talked about autoimmune conditions, which is different. I always think that somebody with an autoimmune condition is born with it. But are there specific phenotypes associated with immune patterns in chronic disease?
There are actually several. For years, for those that work clinically, a while back we thought that a particular protein called C-reactive protein, or CRP, was going to be heavily involved with heart disease. We found out that wasn't true. But we found out what it was a marker inflammation, an active inflammatory marker in the body saying the immune system is turned on. And there's other proteins like that. There's something called interleukin-6 that is just considered a hallmark. If we draw a level and we see that elevated, it says that there's an active process of inflammation going on in the body. Why? We don't know. And if people can answer that, I'm sure somebody will give them prizes in Sweden. But it's one of those things where it's an ongoing process. So this process of kind of chronic inflammation or unsuppressed inflammation might be a better way to put it. But also then what comes in is as we age, there's changes in our immune system that then contribute to this as well. So we lose some of those immunologic defenses that we had when we were younger as we get older. So we start having cells that B cells don't work as well. Our antibodies don't work as well as we get older. We also have a problem that we lose our ability to respond to new things effectively as we get older. Some people feel it's because the class of memory cells that we have are taken up because there's so many things we've been exposed to throughout our lives that there's this class of waiting cells waiting for something to come along, that it's consumed all the available cells for that, and that we're not able to recognize new things and defend against them as effectively. So what's referred to as immunosenescence, age-related immune change, comes in and plays a role with this as well. So we have kind of a lack of cellular response as we get older. Things just don't work as well as they did when we were younger. But we also seem to have this kind of consuming of the class of memory T cells that's all taken up with our ability to respond to all these other things, that if something brand new comes along, we just can't respond to it anymore. And this kind of change in how our immune cells respond and how they manifest themselves in combination with this ongoing inflammation, that's a heavy player in diabetes, which has several issues associated with it in terms that involve the immune system, including the stiffening of vessels. So they're losing their pliability. They don't fluctuate in response to pressure as well. We got kind of a pro-inflammatory, almost hypercoagulability state that some authors have shown with that. Cardiovascular disease is heavily tied with this as well. A lot of the neurodegenerative diseases, Alzheimer's and Parkinson's, as we're understanding more and more of that, we're showing that, this is something that's mediated by basically the loss of certain cells or certain cell types that are heavily mediated by the immune system. So it's just becoming over time more clear to us the role that the immune system in and of itself plays. And so we could say that, well, we'll come to what we can do about this, but there are some things we can do that kind of help stave off some of these changes. But it's these age-related changes in combination with this unsuppressed inflammatory response that's really kind of triggering off this process that we're seeing with many things. And as mentioned, we see this in carcinogenesis, arteriosclerosis, even sarcopenia, which is just an age-related loss of muscle mass. We see these things involved with that as well. So it's a very, very common condition that occurs as we age, and it's probably one of the reasons why we see this huge increase in chronic illnesses as we get older. Now, there's also some things in terms of the type of cellular markers that will change, and so there is some certain types of phenotypes where we see certain cell groups and certain classifications more than others. We'll see certain types of helper cells, but then they're flagged more for inflammatory proteins than others. There's even something called senescence-associated secretory phenotype. And this is something people have been seeing more and more when we start to look at chronic diseases, particularly as an association with aging. And what we're seeing with this kind of secretory, which most people just call SASP, senescence-associated secretory phenotype, is it actually has a really beneficial effect in some ways. It's one of the major things in tissue regeneration, has a major role in wound healing. However, it can also contribute to cancer development. It's linked to arthritis, diabetes, Alzheimer's, and it's one of those things that it's one of these beneficial effects where we have this increase in these inflammatory proteins that are floating around, and then we start getting acute phase proteins, which are tied in with how we clot. And then there's other ones that come out that are associated with body mass and the fat distribution, which also then contribute to a state of low-grade inflammation. So basically, if we're talking about a phenotype, a higher presence of inflammatory markers, such as interleukin-6, CRP, we'll probably see higher levels of what is referred to as tumor necrosis factor alpha, which is a major player in our body's immune response. It's one of the major pro-inflammatory proteins out there, and it's also the target of a lot of therapies that we use nowadays for certain diseases. Tumor necrosis factor alpha neutralizers are actually common in several musculoskeletal diseases, and so we try to target those as treatment. So that would probably be the phenotype or form of expression that we would see.
That's very interesting. And, when you talk about some of these markers, a lot of them are associated with oncology, and I know that they're used to determine specific interventions. But you mentioned, a few chronic conditions that are associated with a specific immunologic phenotype. For those that are practicing clinicians and, interfacing with the nation's largest patient population, those with 2 or more chronic conditions, what should they be looking for? You mentioned something about as we age, and it's always interesting to me to diagnose somebody with rheumatoid arthritis when they're in their 60s and 70s. What specific phenotype or immunologic phenotype should we be looking for clinically in patients who present with chronic diseases?
Unfortunately, we don't have a good assay that would tell us that. What we can look for is we can look for some of these markers of inflammation that can exist. TNF, there's not a really good assay that we can draw for that, but we can look for interleukin-6, we can look for CRP. For some diseases, we look at erythrocyte sedimentation rate as a marker of inflammation. So we can look for markers that say there's a process of inflammation going on, and then sometimes by looking at the markers that are elevated it can start to give us a sense of, what the process might be. But this is really where a lot of the research is trying to head to, is finding a good panel that we could use clinically to identify that this process of inflammation is going on, because it just affects so many disease states. There's a slide that has basically shows a couple of diseases hanging around chronic inflammation: diabetes, cardiovascular, musculoskeletal, pulmonary diseases, particularly COPD, which is such a significant issue, particularly as the population ages. And it's one of those things that it's always interesting that we think of them as distinct states, but the reality is emphysema and bronchitis are often combined together. So we think of these things sometimes as separate disease states because it's convenient for us and that's how we teach them. But the reality is we're seeing things with mixed features. And that's reflecting this underlying immunologic inflammation that's going on here that's really kind of helping. And now, for some disease states, like say certain forms of arthritis, what are we giving? Disease-modifying anti-rheumatic drugs, which are suppressing elements of the immune system. Multiple sclerosis, we're giving basically versions of interferon alpha, interferon beta, which are trying to provide that suppressive quality to the immune system to basically quiet it down and stop that element of inflammation. A lot of the COPD states, or respiratory diseases, will give burst packs of steroids to try and quiet it down. Or even in the cases where you see patients who are in acute exacerbation of multiple sclerosis, we admit them and we give them high doses of steroid because it takes high doses of the steroids to penetrate the blood-brain barrier and suppress the inflammation going on in the brain. Inflammatory bowel disease, we give variants of medications that are trying to also control inflammation there. So in many, many ways, and as you mentioned, cancer, we're trying to give these agents that are trying to turn off our own biologic responses because our body, for one reason or another, has decided to go in a direction that we do not necessarily choose it to go in terms of our immune response.
That's interesting. So you did make mention of some interventions that can be used to disrupt the immune influence on chronic diseases. First comes to mind are non-steroidal anti-inflammatories because there's also a black box associated with them. But I'm in the spine and orthopedic world and do my fair share of managing osteo and rheumatoid arthritis. But, I prescribe NSAIDs all day long. I mean, are there interventions that are more appropriate to alter, the immunoreaction to chronic conditions?
A lot of them would be considered some of those modifiable lifestyle risk factors that we see for many different diseases. There's only so many things that will trigger off this process of inflammation. So there's a lot of shared features across things. Physical inactivity, also then physical activity in combination with obesity, but then diet. There's a huge amount of debate regarding what we should eat, how we should eat it, but it's generally known that the more fatty acids we consume, the worse off things are for us. So basically looking at types of dietary changes in moderation. One of the bigger things that we're seeing more and more of is sleep, and making sure that we address issues of sleep disturbance, which is very common in people with chronic issues, particularly people who have arthritis conditions and who are having a hard time maintaining sleep because of joint pain. People who are kind of self-isolating or feeling stressed, there are a couple of immunologic associated theories of depression that are out there, and they've been accepted for a good 20 years, that there is definitely immunologic association with mental health, particularly with depression and anxiety. And those are the only patterns that we understand. I'm sure there's many more that we just haven't identified yet. But a lot of it comes down to what can we do to maintain as much of a healthy lifestyle as we can, and the same things associated with diabetes. Diets that are high in processed foods, saturated fat, basically large amounts of sodium. We know they're bad for us, but these are the things that we are often conditioned to feel taste good. So it's very hard sometimes to get a diet under control for that. And then we also know, though, that any kind of physical activity, even say 120 to 150 hours a week of anything, is going to be helpful to the person in some way. So some kind of activity. And there are people who look at the effects of chronic, long-term exercise, I should say, versus acute exercise. And there are some benefits that tie to both. So if I'm engaging in chronic long-term activity, so somebody who, say, has been doing some kind of resistance training for years, yoga or some kind of movement-based activity, there are people who are finding that movement-based activities, Tai Chi, Aikido, these things that are kind of low impact in some ways, seem to be very beneficial in Parkinson's. There's some studies implying Alzheimer's, and I know that since we mentioned arthritis, if we're talking about arthritis of the hip, the recommendations are, let's try and control pain, but then what can help it? Weight loss, and what's next? Tai Chi and movement-based therapies. Because the studies imply that yoga doesn't help the hip. It helps the knee, but it doesn't necessarily help the hip. Probably because it takes a long time to get any kind of decent hip flexibility. But all of these things also have an immune effect. So what happens if we have long-term exercise? We have less of these older T cells. So it seems to help our T cell class through the effects of exercise and how it stimulates cells. We have a better ratio of helper cells versus what we refer to as killer cells, which are basically cells that seek out and destroy organisms that are trying to infect us. We have a better turnover of older cells if we're engaged in long-term patterns of exercise. But even if we're not, acute exercise, short-term exercise programs, and by that programs that are like under a week or two, seem to have some real beneficial effects on increasing the amount of what we call naive T cells, which are T cells that can go any direction. So they're cells that are primed to respond to things, and then our body will decide which direction they should go, pro, anti-inflammatory, what have you. There's also a couple of what are kind of mixed pro-anti-inflammatory cells. But we also get more memory T cells. So even engaged in short bursts of exercise for short periods of time seem to have some real beneficial effects. And that's one of the things that we then have to try and, a lot of people say, well, you're just trying to get me to exercise to lose weight, but it's also doing a lot of other things as well. And then also looking at vitamin deficiencies, the B vitamin deficiencies, and their effects on cognitive status and memory are fairly well known. So looking at those, and then the same things that would tie in with anemia. I mean, you're affecting bone marrow, so you're affecting basically all the potential cells there by losing certain nutrients, certain protein deficiencies. Substance abuse, restricting smoking. There's a lot of things we're finding out on smoking cessation that the reality is it's never too late to stop. And looking more at the idea of the harm reduction and what can we do to even reduce the degree of harm that we're doing to one another. Environmental exposures, there's a lot of things out there. Some of the evidence is mixed. We don't necessarily understand them well, but we do know certain things, heavy metals. We know that certain pollutants are things that can be harmful to us. Certain things that we use to control common pests and things like that also have damaging effects to us as well. And as mentioned, understanding sleep disturbance is something we're still looking at, but we're finding that sleep disruption has a significant effect on changing the immune system. It puts you at increased risk for infection. And there seems to be a chronic low level inflammation that comes out as a result of that. So if we look at what a lot of people who have chronic disease have going on, sometimes it's physical inactivity, sometimes it's because of the pain of the disease states that they have. They may have a poor diet because it's difficult for them to go to the store, or maybe they're in a neighborhood that has some food desert issues in terms of getting nutritious food conveniently. Maybe they're not paying attention to how well they're eating. They might not be sleeping well. And the entire thing that we're starting to look at even more now is what's going on with our GI flora. And then there's been a body of work over the past 6-7 years of looking at gut microbacteria and seeing what's going on there and how that plays a role, because the largest group of immune cells really inside our body is in the GI tract. And it helps defend us from foreign things. But then also, if those cells get thrown off, then we're seeing dysregulation that occurs on with other issues. So it's one of those things that it's like, yeah, none of this is quite as simple as we'd like it to believe.
No, very complex. And, while you're talking about some of these things, I, in my mind, think about all of the dehydrated patients that I see and how much hydration has to play in inflammation in the immune system.
It really does. Maintaining, again, appropriate hydration, appropriate diet, also including fluid. And I think that's one of the things that we often see, unfortunately, with older adult patients. They're not maintaining an appropriate level of hydration. Sometimes why? Well, I have a patient, bilateral hip issues, had been obese much of her life, lost a lot of weight, but has really bad hip osteoarthritis. She doesn't want to. She has blood pressure issues, but doesn't want to take anything that has a diuretic because it's not easy for her to get up and go to the bathroom. And that's a very common issue with a lot of older adults. How do they control the amount of times they go to the bathroom? They stop drinking. And then we run into those situations of hydration that we see commonly in people because they're trying to control the situation, but they don't understand the flip side of what they're doing. That it also is then setting up for other issues down the road. Or they're eating something that can be quick. They're eating something high in processed fats and sugars. And it's quick, it's easy, it's not difficult for them to prepare, but it's also not really helping them from a dietary standpoint in many ways either.
Dr. Sorenson, I'm always concerned about patients who have received multiple corticosteroids from other providers. They go to one provider, they get a Medrol dose pack. They go to another provider, they get a Solumedrol injection, or they're getting, facet injections or hip injections with steroids. And how many, is there a limit of the amount of steroids that someone should have that's going to influence the immune system? Is there any data to support that?
There's data that's known that basically any steroidal use, even for a short period of time, has a suppressive element on the immune system, and which is intentionally what's being done, because steroids suppress. Without getting into the detailed process of it, there's a major inflammatory response that regulates, that's nuclear factor kappa beta pathway. It's one of the major inflammatory pathways we have. And what steroids do is they stop the expression of the messenger RNA for that pathway. So the inflammation doesn't happen. But then it's also affecting everything else in that pathway. So we know that any significant period of time for steroids is going to put you at increased risk for infection because we're turning off that defensive element of the immune system. And then chronically down the road, we know that it's going to put you at increased risk for hyperglycemia because it increases the turnover of glucose within the liver. So we're going to see higher blood sugars. We're going to see a lot of type 2 diabetes that can result from long-term diabetes use, long-term glucocorticoid use, basically any steroidal use over time. Ulcer development within GI tract. There's just so many things that get involved with that, and unfortunately there's no clear guideline that says when has this person had enough steroids. And sometimes, unfortunately, for some things, that's the only thing that can seem to help manage the exacerbation. But I think this is also why you're seeing a lot of warning notices for some of the guidelines lately that steroids are only to be used in this situation to handle an exacerbation. They should not be used in ongoing regulation of the disease, because then that's when we start to see the adverse consequences of using steroidal approaches. Can they shut off inflammation? Yes, and they do it well. But there's also other elements of that pathway that they're turning off that are necessary for health. So we're not just shutting down the inflammation, we're shutting down other components, other parts of that arm of the immune system, and we're placing ourselves at increased risk for infection while we're doing it. So they're working as they should, but it's not without cost, and that's where that risk-benefit analysis on the part of providers is supposed to come into play. Is this helpful for this person or not? And in many ways, we know it's what's going to work, but then we also know that there's going to be risk for it, which is why, again, a lot of the guidelines are saying exacerbations only, not ongoing treatment.
Yeah, not too long ago, the global lung obstructive guidelines, the GOLD guidelines, identified, prolonged use of corticosteroids actually precipitating pneumonia in COPD patients. So it is interesting to see how the guidelines are changing. Dr. Sorenson,
particularly the use of oral steroids, which have
Yes.
a slightly different pathway, because there's also within the GOLD standards low-dose inhaled steroids that will have a local effect only, that do not necessarily have the systematic effect, are now used as reliever medication under the last couple sets of GOLD standards. But yeah, the consumption of oral steroids that are going to have a systematic effect really needs to be done with caution. And I'm sorry, I believe I cut you off.
Oh, no, you're fine. I just wanted to also acknowledge that you are a member of our editorial board. And is there anything else that you would like to say to our audience as it relates to chronic disease in the immune system? You've given us a really impressive overview, and I've learned a lot from this today.
I think it's one of the things that we don't think about a lot of the times. We think about all these other causes of the disease, but then remembering that there's this major bodily system that's intimately involved in this. And the more, hopefully, that we see the research and we're aware of it, that can hopefully guide some of the treatment decisions and some of the future research that we're doing.
Right. All encompassing, and not just focusing
it is.
on the disease itself. Yeah. Well, we appreciate what you do for patients and students and the Multiple Chronic Conditions Resource Center, and thank you. We will make sure that we post your slides with this podcast so that the viewers can also refer to them as well.
Okay. Thank you for the opportunity to speak with everyone today.
Yeah, absolutely. You take care.
Thank you.